many people smile, right? But behind the smile is a lot of pain. In girls, the internalizing symptoms are more. So anxiety and depression are more. Women are supposed to be shy. They're supposed to hide behind things. They're not supposed to be so open to talk about things. So the subtle signs of depression are change of behavior, change of eating, any change which is found by the parents can be discussed with clinicians.
Hello everyone, welcome to India Autism Center podcast, a trusted platform and your go-to destination for meaningful and insightful conversations and expert guidance on neurodevelopmental care, autism spectrum disorders, and above all, empowerment of parents and community. I'm your host for the session, Pooja Datta. Today we will be exploring a very complicated yet very relevant topic, that is the co-occurring or the comorbid psychiatric conditions that may be associated with autism. And in order to explore this topic and give us more insight, we have with us a very reputed consultant psychiatrist in Kolkata, Dr. Sarmishtha Chakrabarti.
Hello.
Hello, ma'am. It's an honor to have you here at the show.
Thank you so much. Thank you to India Autism Center. And it's lovely to be back to this podcast today.
Thank you, ma'am. Ma'am, before we start this podcast, I would like to have your experience about your professional journey and how did it align with autism care?
Well, the first 10 years of my professional journey was in England. So I got trained in England and I was associated with Cardiff University Hospital. And for 5 years, I was there in the child and adolescent unit. So my journey with autism started first there. And I think from my age of around 30 to 35, I worked with little children and adolescents who had autism related disorders. And after that, in 2005 end, I came to India. And since then, I've been working in Ramakrishna Mission, Shiva Pratishthan. And I'm still working with Manipal Hospital in Salt Lake. So I also go to villages to cover the whole society, so I cover the rich, the middle class, as well as the poor population. And I see a lot of autism spectrum disorders. And I have to say, over the last 25, 28 years I've been working, I have found more and more children being diagnosed with autism spectrum disorders. And there are many researches and many treatments which have come for the comorbidities of autism spectrum disorder. Because if you think about it, patients or really, children with autism and their parents come to us, to a psychiatrist, A, for a diagnosis, and B, the main reason is because of comorbidities. So that's how I came associated with autism spectrum disorder. And after that, with India Autism Center, of course, it was, when it started in Kolkata, many of us kind of got associated. And we're so happy to see leaps and bounds of progress in research as well as in the treatment and the, whatever has been done by the Indian Autism Center.
Thank you so much, ma'am.
Yes.
To begin with, even to the parents out there, what do we mean by comorbidities? And what are the common comorbidities that are found in children with autism spectrum disorders?
Okay, so comorbidity means, if we speak about general diseases, comorbidity means the main disease and along with it, the diseases which are present with it. So in case of autism spectrum disorder, I think the commonest comorbidity which we see in our clinics is ADHD. ADHD is around 35% of autistic children have ADHD. And then, 80% of cases of autism have comorbidities. One comorbidity will be there, and maybe sometimes multiple. The second, pretty common, around 40%, is anxiety disorders. Anxiety disorders, if you think about social anxiety disorder, social anxiety is present in as a core feature because social communication problems are there in autism. So it's very difficult to differentiate, but many children with autism suffer from anxiety disorders. Next is OCD. About 25% patients suffer from OCD. And again, it's very complicated to kind of differentiate from other repetitive behaviors of autism. Then we have epilepsy, and epilepsy is very difficult because many parents, they have to cope with a lot of behavioral problems of autism. And then when the child has epilepsy, the parents get, very upset and they come to us, what has happened? Will my child suffer forever? And will the medicine continue forever? So epilepsy is next comorbidity. There's another problem which is very difficult, that is sleep-related problems. Many autism children have sleep difficulties, and they, throughout the night, they have disturbing behavior, flapping, crying, shouting, and then throughout the day, they have reversed their body clock. So sleep disturbances are also there. And of course, other behavioral problems are there. We have comorbidity of hypertension, diabetes, multiple endocrinological problems, neurological problems. So we can say that many comorbidities are present in case of autism. And if you consider psychiatric comorbidities, ADHD, anxiety, depression, OCD, sleep-related problems are quite common.
Before jumping into the next question, please have a look at who we are.
Imagine a space designed not just to care for individuals with autism, but to empower them. A place where knowledge grows, support flourishes, and possibilities expand. This is India Autism Center. It is built to redefine how we approach autism. Through education, research, and community-driven initiatives, we create an environment where individuals with autism can thrive. Samavesh, our residential campus, is designed for individuals with autism to live, learn, and grow with dignity and independence. It is more than just a place to stay. It is a space to belong. Manan, our training academy, prepares professionals to provide specialized care. Through structured programs, we equip individuals with the skills to support neurodivergent communities with confidence and compassion. Khoj, our research division, is dedicated to advancing our understanding of autism. Through data-driven studies and collaborative research, we work towards shaping the future of neurodiversity.
In your clinical practice, ma'am, when you see children with autism who are having co-occurring conditions, like you said, ADHD, anxiety, depression, or other psychiatric conditions, how early can these underlying comorbid conditions be detected in children?
Yes, I mean, to diagnose autism, parents take about, things have improved, diagnostic criteria, many parents are aware, pediatricians are making them aware to many of the parents. But however, to diagnose it takes about 3 years or so. So if we consider ADHD, the age is between 3 to 6 years, because a severe ADHD child is difficult to sit In that case, the child will have difficult to sit with the speech and language therapist, for example, will have difficulties in the ABA therapy session, will have difficulties in school, in the special school. So we see between 3 to 6 years, a lot of children come to us with ADHD. Now, if we consider OCD, in case of autism spectrum disorder, we see OCD a little bit earlier than with the children who do not have autism spectrum. So here we can find children, I've seen OCD in children with autism who are about 8, 9, which is of course, quite early in autism. So between the age of 8 to 12 and 13, we see a lot of people with autism spectrum disorder who have OCD. Then epilepsy. Epilepsy can come at any time. We cannot predict which age epilepsy kind of comes in. So epilepsy can come in with adolescents, even with adult autism spectrum. They're going fine. Suddenly they have a fit. We cannot kind of predict the age of epilepsy. Then depression and anxiety. Anxiety disorders, that is also pretty early, with the age of 2 to 8. So it's pretty early for children who have starting with separation anxiety, starting with, when they go to school, their anxiety is kind of, it is felt in a different way, maybe with a behavioral problem, maybe with a temper episode, biting, screaming, flapping movement, or any other behavioral problems, even sleep problems. So I think it is earlier than children who do not have autism spectrum disorders. So in case of, these are the main things we have where we find that children with autism present a little bit early, but for ADHD it is around 3 to 6 years, which is the commonest comorbid diagnosis we have with autism.
So, ma'am, in relation to this, the one that you said, at times it happens, children with autism, they're not able to express their underlying anxiety or their underlying psychiatric conditions at times because self-expression is impaired in autism. How do you come across about these psychiatric conditions then? How do you assess this?
It is very difficult. Many times we miss also. Many times we miss. See, I have a young man who is 31. And now he's got a diagnosis of autism spectrum disorder at this age. So it has taken, and he has been an odd person. He couldn't communicate well. He had very poor kind of, educational performance, and he was bullied like anything. And he had very, very, educated parents. And they actually thought he was lazy, and he had lots of money. So he was always into gadgets, and he was into, he was not at all social. So at this age, he comes and he gets a diagnosis of autism spectrum disorder. So we can understand that comorbidity and autism, separating the two, because the core features are a lot to do with anxiety, with social anxiety. How do we understand that the child has anxiety disorder? Okay, now what we feel is we understand, how do we differentiate? ADHD is quite typical because ADHD has hyperactivity. The child is running around, not sitting. The child is very disorganized, very impulsive, beating other children, scratching the mother, shouting. So ADHD is very typical. It is much easier to diagnose. However, if you have an OCD, repeated things are very common with OCD. People constantly count, or they might do some, 5 times they might hit somewhere, or they are saying the same thing over and over again, or they are checking. So these things are part of OCD as well as kind of part of autism as well. So it is just that clinical eye of seeing patients around patients and understanding the difference, that this is the problem in the child. And of course, if you have a family history of OCD, if you ask the patients that, did your mother have OCD, or was she a little bit, in Bengali we say chuchibai. So she was into cleaning and she was into checking and all that. So sometimes we find a family history. And of course, if there are clinical signs of anxiety and depression, then also, like, if the child's personality kind of suddenly changes, and the child is sad, is not eating, or is not eating at all. I have forgotten about anorexia nervosa, which is also a kind of comorbidity which we find. Eating disorders are comorbid with autism spectrum disorders. So eating related problems. So if the child is not eating, the child is not sleeping well, and the child behavior becomes very disruptive, in that case, it could be, or there is some sort of social reason for the child to behave like that. Maybe a near dear person has left or passed away. In that case also, there can be a diagnosis of depression. However, clinical eye is the only eye. And I think after seeing years of patients, then only you can diagnose a child who has anxiety, depression, OCD, ADHD. So it is but difficult. You're right. The comorbidities are morbidities of both. There is a huge kind of overlapping between the two. So we have to diagnose when clinically the person presents a few features, and it is more about experience of seeing children with autism.
Right. So, ma'am, this will also be very insightful for us and the audience watching there. What are the early indicators that a child may have certain underlying distress or disturbance that cannot be overlooked?
Yes, see, early indicators, as I said, that, very early you can find ADHD. Very early. The child is not sitting. This can be, we find ADHD very early, below the age of 3 sometimes. Yeah, the parents bring that they are uncontrollable. They are, all over the place, running around, going away from other children, just aimlessly running around, and, so that early diagnosis with ADHD is very...
Ma'am, these are all external. It can be observed.
Yes.
But regarding some internalizing conditions like depression,
Yes.
the child is having some underlying sadness,
Yes.
or is going downwards towards
Yes.
low mood depression.
Yes.
So what are those subtle red flags that parents
Subtle
should
red
observe?
flags will be if the child kind of a change of mood. Change of mood means the child was otherwise happy. The child was going to school, they had a routine, but now suddenly the child is not eating well. Because again, gastrointestinal problems are very common with autism spectrum disorder. So the child might not eat well, again, might not eat well because of gastritis, because they had diarrhea, or, maybe they have indigestion. So this is so difficult, because you have to understand, when you see how early is the early subtle signs of depression are low mood. If the child has, because depression is, you're right, the features can't be evident. It's not, evident. It is more of kind of subjective than objective. So people say, I have low mood. I am I cry most of the time. I don't concentrate. I don't sleep well. I don't eat well. I don't feel hungry. I feel that, the world is ending. I don't feel like living anymore. What will the autistic child say?
Exactly.
What is a child with autism going to say? Because the child cannot express himself. So the subtle signs of depression are change of behavior, change of eating, any change which is found by the parents can be discussed with clinicians. Who are the clinicians? Psychologists, psychiatrists, speech and language therapists, maybe, some, the ABA therapist, maybe pediatricians whom they are going to. Anybody, they can see the subtle changes that the child is suddenly not eating. The child is suddenly not sleeping at all. So, what is the reason? Now, the reason can be simple things like worms or gastritis, right? But then the child has to be clinically seen by the pediatrician. Really, is there gastritis? It's not cured with PAN 40. So, what is it? It is something, and then, if the history, detailed history has to be taken by the professionals. That's so important. Psychotherapeutic history is the most important thing which we do in details. Psychologists do in details. They take a history and then kind of diagnose, okay, right, this is depression, this is anxiety, and the anxiety has come from 1, 2, 3, 4, 5. These are the reasons the anxiety attack has come now. So, any problem with the parents see a change of behavior, change of biological symptoms of depression like not eating, not sleeping, change of behavior, irritability, the child is spitting, or the child is, which was not a behavior before, it's a new behavior, then the parents can be worried that must be there is some mental health problem that is causing this symptom.
If you feel that this session, it is quite meaningful, relevant and impactful, please do not forget to hit the like button and share this video so that parents and audience out there, they get empowered. Coming back to the podcast, ma'am, you have been an advocate of women mental health.
Yes.
You have worked immensely with women.
Yes.
How do you see autism as manifested in girls and women in contrast to boys and men?
Yes, women, as we know, that women internalize a lot more. In autism spectrum disorders, women internalize a lot more. So we see, as it is, anxiety and depression happens more often in women. And in men, the symptoms are more of externalizing, like ADHD, anger outbursts, temper tantrums. So more often we see anxiety, depression and OCD in women because they internalize. Now, I think one of the questions you kind of said, how do we know that it is, how do you differentiate between mental health disorders and autism spectrum disorders? Because sometimes it's very overlapping. See, when we think about OCD, the characteristic feature of OCD is the patient does not want to do the, repetitive behavior. Right. It is ego dystonic, means person is doing against his wishes. They are not enjoying it. So that is OCD. But in case of autism, when they are flapping or when they are counting or when they are playing with toys, repeatedly they are doing it, it is egosyntonic. So the person likes doing that. It is quite enjoyable for the person. But OCD is something with the person hates doing it. It is not a happy place. So that is one of the things which is different in OCD and autism. However, coming back to a question that in girls, the internalizing symptoms are more. So anxiety and depression are more. And the boys have ADHD and aggressive symptoms, which are more in case of boys. And in, if you consider women mental health, what we find is that many many autism. Previously autism was not a diagnosis, but it was there. And many of the women got married and they have children and they have successfully kind of had a successful married life. But the oddities were there. Okay, and they used to be hidden. And they were pretty happy to be shy, hidden in their closet and with their children. They were happy in their little space of their home. So, when we say Indian women, it is more difficult because in women, we have women who are supposed to be shy, who are supposed to not talk about their problems. And if they are quiet, nobody, kind of says it's abnormal. So, women, it is that way. That is, they are it's misdiagnosed as they are shy and they are not talking and they are running away when somebody is talking to them. And so they say, no, she's a girl, she's very scared and she's very shy. But it could be an autism spectrum disorder. So that's where the misdiagnosis kind of comes, or the diagnosis comes pretty much late, after the age of 5, 6, when actually they go and face some problem in school. And then the teacher said, no, this is like, this could be an autism. Please get her diagnosed or rechecked. And then they come to us. So women, that way diagnosis is a little bit difficult because of the cultural kind of thing which goes on, that women are supposed to be shy, they're supposed to hide behind things, they're not supposed to be so open to talk about things. So that way women are different than men.
In addition to this, ma'am, we often hear about masking.
Yes.
In both boys and girls, but girls, the tendency to mask, it is often said in ASD, it's much more than that of boys.
Yes.
So, ma'am, what's your take on it?
Of course, masking is, women always, many people smile, right? But behind the smile is a lot of pain. We know it, right? In depression also. People go to the office, they smile, and we see a lot of people who actually came back. I lost many patients that way. Bye-bye, doctor. And they smiled and, kind of said goodbye, but they went home and they committed suicide. We have, so basically it's masking is a very dangerous kind of thing for us, at least, because we don't understand what is going on in their mind, more so in autism. In autism, already expression is a very big problem. And then if you have a problem, I think that can be masked very well by the diagnosis itself. So if you have a problem, you are hiding it. You cannot express it properly to people that, I am not feeling like, going out today, or I'm sad. Saying that is also difficult. So masking is very common, of course. And how they mask it, but sometimes we understand by these biological symptoms, that they're not sleeping, they're not eating. Suddenly they stopped eating, stopped talking. They were talking to their parents. They had communication, which has stopped now. So those are the things. And if they're smiling also, but they've stopped other things which were pleasurable to them, I think then the parents can understand, okay, this could be a cause that the huge change has come, but they are not expressing their problem to us.
So this is really very insightful, ma'am, because we see a lot of parents at times, they don't understand because the signs are so subtle and the child is suffering inside. So it is even our responsibilities to share and spread this awareness.
Sure.
And so that even others, they come to know and they can at least detect and they can send that individual to a professional.
True.
This is very, very nicely said, ma'am. I hope the parents, they are watching there, and the way you discussed about OCD, the difference between OCD and autism, these are all very meaningful for the parents.
Thanks.
Thank you so much, ma'am.
Thank you.
So, ma'am, moving to the next question, or rather, most of the times parent, they ask us, what strategies do you people as professionals, you adapt to when you see cases which are having underlying comorbid conditions? So what kind of strategies apart from the management strategies of ASD do you give to these individuals?
Yeah, it is always multidisciplinary. That is most important. You know, when a young child or an adolescent comes to us with autism spectrum disorder, I think we understand that there is a diagnosis, say ADHD, or say depression or anxiety. If we see that, I think there are a few, in your head it's going like, who are the multidisciplinary team I'm thinking about? I am thinking about the psychologist who is going to do cognitive behavioral therapy and individual psychotherapy to the child. I'm thinking about the speech and language therapist who is going to help. I'm thinking about the occupational therapist who has to be involved now more so. Many times when the parents see that, okay, they are much better, I think they are also tired, going through the so many sessions of OT and speech and language and going through so many people, they are also tired, so they stop going. In that case, those things have to go up, because if somebody suffers from OCD, I think the primary should be CBT, exposure response prevention, deep breathing exercises. All these need to be taught to the child. And of course, if they have epilepsy or if they have sleep related problems, we also have medication for that. And we do give medication for epilepsy until they are, they are fit free. And so it is multidisciplinary and it involves so many people, and the parents and the child being in the center. So we are there all around, trying to get the child better, trying to get the autism spectrum disorder plus the comorbidity better, and how the parent can handle it better. So many people need to get involved when a child has mental health problems in an autism, because autism spectrum disorder, you have to remember, 80% has comorbidity, and comorbidities need treatment, even if it's thyroid problem, if it is epileptic problem, if it is sleeplessness problem, everything is affecting the child, and everything can be sorted. That is the most important thing. There is nothing like can't be treated. Everything can be sorted. It happens to everyone. Even little children suffer from, alteration of body clock, and they don't sleep well, and the parents are, all over the place. What will happen to me? How will I go to office? How will I do my work? I am shattered throughout the night. He was disturbing me. He was shouting, and his father couldn't sleep. His grandparents were there. So the whole family had difficulties. But what is the cause of sleep disturbances? Is it physical? Is it psychological? Or it could be a circadian rhythm problem. So these need a proper treatment, aggressive treatment, and it goes. So I think it's important to understand that the positivity of this, it can be treated. There is lots of hope. A multidisciplinary approach with everybody has to work as a team. There's nobody who is higher up in the hierarchy. Everybody has similar and important, and importance of, they have their own importance to make the child's difficulties better. With a lot of empathy, of course. It won't be easy, and the parents will be anxious as well. What has happened to my child? So I think there's a lot needs to be done by all the professional. Multidisciplinary team needs to do it.
Thank you, ma'am, so much for your practical inputs and guidance. But we won't leave you now. Before wrapping up, we will have a very short round of true and false. So I'll be asking a statement and you will have to tell me whether it's true or false with a short explanation. Ready, ma'am?
Yes.
All children with autism will have at least one co-occurring mental health condition.
No. As I said, it's not necessarily. 20% won't, have a comorbidity. So, no. The answer is no.
Medication is the first line of treatment for managing co-occurring disorders in children with autism.
Definitely no. A big no. Before prescribing medicine, we have to think that we are dealing with an autism spectrum disorder where medication might not be tolerated that well. And even if they are ADHD and they are not sitting in speech therapy at all and they are hugely hyperactive, then also we think twice and then give the proper medicine. There are lots of medication. So the answer is no, but it's not the first line of treatment.
If a child with autism is showing signs of aggression, it's likely due to a co-occurring psychiatric issue.
Not necessarily. No. Because, if they have behavioral problems, it could be that his main carer has left. Not necessarily. They are irritable or they are, it could be worms, as I said. It could be a gastric infection or it could be a fever. So no, not psychiatric. Not at all.
Diagnosing comorbidities in autistic children under age 6 is often unreliable.
Well, comorbidities, many of them overlap. So diagnosis is very difficult. About whether it's unreliable, I would say, maybe yes, because of the huge overlap between the two, many symptoms overlap. So the diagnosis is quite difficult. That is what I'll say.
Once diagnosed, co-occurring psychiatric disorders in autism stay the same throughout life.
Not at all, no. The reason is with treatment, it gets better. There is proof, there is research, it gets better. So definitely no for that one.
Thank you, Dr. Chakrabarti, for sharing your expertise with such compassion, empathy, and care. So it is very difficult to get such a comprehensive idea where we are talking about autism as well as putting an emphasis on co-occurring conditions. Thank you so much.
Thank you. It was my pleasure. Thank you. In the Autism Center.
To the viewers watching there, if you feel that this conversation matters, if you feel that you have had some important inputs from this conversation, from this meaningful interaction, please do hit the like button and share this video so that others as well get empowered. Until our next video comes, please have a look at the video that is popping on your screen. Thank you so much.